Okie dokie. Hi, folks. So this is a presentation I do keep updated, but it's generally a presentation in the context of medical student or residents in training, um, grand rounds or noon conferences. So it's designed essentially as a 1 hour talk, with time for a Q&A. So if folks need to leave early, I certainly understand. And let me switch over to the slides. I want to thank some of the pharmacists for single payer out of PNHP, as well as the great Peter Arno for assistance in vetting of some of these slides. But I take full responsibility. And let me just get the share up and we are off. Can somebody give a shout out that it's all visible?
Yep.
Okie dokie. So here we are. The price is wrong. U.S. prescription drug prices. So I'm going to give a quick review of what is single payer, go through the international comparisons, why all the other rich capitalist democracies around the world, what they pay compared to the U.S., and then answer some of the questions around, but what about research, which is typically the issue of concern that gets raised, completely disingenuous and dishonestly. But unfortunately, things get even worse in recent times with the completely nonsensical invention of pharmacy benefit managers, just a further way of ripping us all off. The impact of excessive drug prices, in terms of, they're not just high, but the fact that they're high is actually causing harm, and then finish up with what we can do both in the short term and the longer term. So yes, the price is wrong. So disclosures, no financial interests. I'm with PNHP, a nonpartisan, nonprofit educational issue advocacy organization. You guys know single payer, but just to quickly review, single public agency organizes the healthcare financing. It's public financing, but the same mix of private and public delivery that we have now. It is not a national health service like in the UK or what the VA or DOD have here in the US already. The doctors remain independent practitioners, not government employees. Includes all medical necessary services, no copays, no deductibles, no out-of-pocket or other point-of-service costs, medical, mental, dental, long-term care, hearing, vision, of course, prescription drugs, our topic of the day, as well as medical supplies, and covers everyone in the United States automatically from birth to death. Again, it's health insurance, it's the financing, not the delivery. I like to use some popular with our more conservative friends buzzwords. So on the one hand, it's very important that it is progressively funded, but it also provides security. Yay, security. Everybody always has it, regardless of any other changes in your life, circumstances, your jobs, pandemics coming and going, and it provides greater freedom of choice since all the doctors, hospitals, and pharmacies take it and everybody has it, then there's no limited networks and you have greater freedom of choice as a patient to choose any doctor or hospital you want. No point of service costs, very important in terms of blocking access to care. So once again, why our system is so broken in the United States. We get terrible bang for our buck. Here in the United States, we pay over 50% more per capita in healthcare services than the rest of the rich capitalist democracies around the world, but we have a lower life expectancy. And the divergence is actually getting worse. And so what this is showing is that bang for the buck of life expectancy versus healthcare expenditure per capita from 1970 through 2018. And while the United States in 1970 was at the bottom of the pack, as you see in the lower left, the divergence has actually been acceleratingly getting worse. And this suggests that the excuse that is often given that the US is an outlier because of our unique history with regard to enslavement of persons kidnapped from Africa, and our whole racist history, as well as some of the other immigrant history that the United States likes to think itself as is unique. Well, that was all true in 1972. And the divergence getting worse suggests that there's something else going on, and that those diversity and racism explanations don't fully capture why the US is different from all the other countries. And the fact that there's something going on as a matter of policy in the United States since the mid-70s, making things even worse. And basically, it's the whole neoliberal agenda of acceleratingly privatizing public goods and pushing everything into the financialization sector. The US does worse in overall medical system healthcare outcomes. This is showing deaths per 100,000 population due to avoidable causes of death. So it's a subset of causes of death per ICD coding, for those that are familiar with that, which are thought to be preventable, avoidable due to medical healthcare, public health interventions. And what we see here is the United States back in 2009 is worse than all the other peer countries. And then 10 years later in 2019, all of the countries have improved, but the improvement in the United States is far less than the improvement in the other countries. And so we're falling further and further behind in these avoidable deaths per 100,000 population. One of the other problems with the status quo, which, by the way, a public option does not solve, is the fact that our healthcare system financing is regressively funded, which is to say that persons at the lower level of income, as shown on the left side, pay a higher percentage of that income, and people with a much higher income, as shown on the right-hand side, who have more disposable income, are actually paying a lower percentage of that income in our current system on healthcare. Public option shifts the curve downwards a little bit. Single payer reverses and flips the curve. And so for lower income folks, middle income folks, they would be paying a far lower percentage of their income under single payer. In other words, basically 90 to 95% of persons would have, and households would have an increase in their annual income while getting guaranteed health care with no point of service costs. And only the highest 5% would be paying more. We often hear this argument around rationing. It's simply false that bringing in single payer would result in rationing. In fact, it's the United States that currently is rationing. We just do it by the ability to pay and the ability to access care if you're not in the upper middle class or rich. The US patients skip care more often due to cost than do other persons living in other countries. And in fact, it's so bad that if you look in the darker teal color in the United States, amongst our higher 20th percentile income, 27% report skipping healthcare due to ability to pay, even in that highest 20% quintile. And that's higher than the lowest income folks in these other peer countries. So again, our system is so broken, it so blocks people from accessing care due to out-of-pocket costs, that even our highest 20% are worse off than the lowest 20% in other countries. Basically, the solution of 40 years of free market for-profit reform has been to add additional for-profit middlemen, extracting both public and private dollars for their own profit. This includes Medicare Disadvantage, managed care, pharmacy benefit managers, etc. We've also raised the unit costs in the United States far more than other countries. This includes the cost of drugs as well as other things. And then more and more ways of diverting public and private doctors, private dollars to Wall Street. Limited networks, copays and deductibles, restricted coverage, prior authorizations, increasing monopoly power, driving up costs, as well as accelerating investor-owned third-party for-profit corporations, which have a quarter-on-quarter demand of increasing their earnings and/or profit. So the solution over the last 40 years has been to make it more difficult to get care, rather than finding a more efficient way to finance the system and actually deliver care. The changes have harmed patients. They frankly have harmed doctors and hospitals and other providers of care, has not limited control total costs. It's just diverted money to the for-profit sector, and it limits access to care. We use less healthcare than other countries. We have worse health outcomes than other countries. We spend more than other countries to achieve those bad outcomes. To the for-profit policy has basically been to extract more money from the public into their own coffers. And as George Carlin said, in terms of our frustrations of getting this solved, as George Carlin said, I don't believe there's any problem in this country that no matter how tough it is, that Americans, when we roll up our sleeves, can't completely ignore. Thank you, George Carlin, RIP. So expanded Medicare for all, why do we think it would actually help and make for healthier Americans? Well, the US ranks dead last overall among 17 peer countries in age group specific mortality rates for most age groups from 0 to 64. Occasionally we climb up to second from the bottom, but we're pretty much last overall until we get to age 65. And what happens, of course, at age 65? Well, that's when Medicare, what I like to call Medicare as is, kicks in. And when Medicare as is kicks in, what we suddenly see is that in the United States, age group specific mortality rate all of a sudden shoots up. Turns out Medicare as is provides better access to care than the rest of the system. And we start doing relatively well in terms of the US rankings among 17 peer countries. And in fact, in the oldest age groups, we are number one. Whereas from age 0 to 65, we are number 17 out of 17. So sometimes when I'm presenting this, it's not to necessarily a single payer audience. And so I say, well, okay, if you're not for a single payer, fine. Here's the critiques of the US system. And I go into that in my general single payer talk, which is much more detailed on that. But I would suggest that you want to come up with something that's universal, simple, and affordable. In other words, is your healthcare solution like mine, is it truly USA? Okay. So that's the quick summary of single payer. Let's get to the American prescription drug costs and why how much we're paying, why we're paying more than other countries, and what we can do about it. So first to set it, so let's remember, these are all multinational, or as I prefer to call them, transnational companies, Pfizer, Merck, etc., providing the same drugs from the same companies to all of the other rich capitalist democracies around the world. I mean, we know recently Wegovy is, coming from, is it Denmark or Sweden? It's apparently boosted the GDP of the entire country by so much with that one single product from one single not USA-based company. But basically what this chart is showing, and this is actually coming from AARP, which provides wonderful data each year. Wish they would support single payer, but they don't, because they're basically an insurance company masquerading as a elders advocacy group at this point. But they do provide wonderful data on prescription drug prices. And what we see here in the gold line is the general inflation rate each year from 2006 to 2020. And by comparison, what we see in the blue bars is for the top 260 drug products, what the brand name drug prices inflation rate is each year. And remember, this becomes cumulative year over year, where it's an added percentage based over the added percentage in the prior year. And so what it adds up to is over this period of time is that for brand name drugs, they're over 300% higher prices And generics, which were supposed to be the solution, but have in fact resulted in a fair amount of, if you will call it politely, cheating, have an over 700% increase in price over this time. And again, far higher each and every year than the background inflation rate. Another way of showing this, the 49 selling brand names of drugs from 2012 to 2017, 78% had an increase in the insurer and out-of-pocket costs by more than 50% in that time period. 44% more than doubled in their prices over that time period. The system and the individuals, just cannot live with this level of drug prices rising so much faster than general inflation rate. Again, U.S. brand name originator drug prices as a percentage of other countries' prices overall. Again, this is from the center-right RAND Corporation, not a single-payer supporter. Certainly nobody's idea of a liberal organization. And again, they're showing for these other countries, we are roughly around 3 times or more the drug prices in 2018. Another one looking at the same thing, this is from JAMA, comparative drug prices of top selling drugs, the US compared to Canada, France, and Germany in 2015. And again, you can see that Canada, France, and Germany, and the average of those 3 relative to the US, they're all discounted, roughly in the range of minus 53% on average by comparison. In other words, roughly half. The U.S. spends the most on drugs, again, 1.5 to 12 times the price for any of the other drugs. Again, more expensive, another way of looking at it. So multiple folks have looked at it in different years. This is actually the one from the Ways and Means Committee back in 2019, when after the election or going into the election, they were looking at with Build Back Better, HR 3, and there was some analysis being done by the Democrats showing just how bad the drug prices are. So the Democrats in Congress were actually looking at the same data that we're looking at now and realizing this makes no sense whatsoever. The same drugs, other rich capitalist democracies around the world, our peer countries, why are we paying more for the same drugs from the same companies? It makes no sense. Maybe Medicare ought to be able to negotiate rates. U.S. Medicare pays more for drugs than older adults in other countries. Older adults in these other countries all have the same kinds of diseases. This is looking at outpatient drug spending for older adults with a prior history of hospitalization for heart failure with a comorbidity of diabetes. In other words, going to be on multiple drugs for heart disease and for their diabetes. The clinical protocols are roughly the same in these different countries in terms of what we physicians prescribe for them. And what you can see here is that the outpatient drug spending is far higher in the United States for comparable persons who are over 65 and have these health conditions compared to their peers of the same age with the same health conditions in other countries. And again, it's not that the number of drugs that we are prescribing in the United States is more. Let's say, those other countries, they're not getting the same number of drugs, they're not getting the same level of treatment. They must be rationing care to save money. No. In the dark blue, what you see here is the number of unique drugs prescribed. The United States falls in the same range as the other countries. Some of them are actually prescribing more different drugs than we are, as shown in the dark blue and the Y column on the right. However, the cost per drug, shown in the green and the Y column on the left, is far less in those other countries. If we're following up with the price is wrong, we need to go with our friends at Sesame Street and notice that one of these prices is not like the others. So here's some of our peer countries and how much they pay for this fixed combination drug that's used for asthma and COPD. Again, the same combo is available in all these other countries at this price, and look at the United States by comparison. So again, to quote our friends at Sesame Street, one of these countries is not like the other. We in the United States are being completely gouged. Now, it's been recently the case that there has been a strong push to make insulin in the United States less expensive, and that's great. The T1 folks, the folks living with insulin, with diabetes type 1, have done a very good job of lobbying for themselves. They are the most vulnerable, if you will. If they can't get their insulin, they're going to die in the very short run. So it certainly was certainly the most acute problem. I think it was also the most politically viable, easier fight, sympathetic folks with diabetes, the type 1 diabetes. And so there's been some success in getting some price controls on insulin, given the extensive gouging and rising in prices beforehand. But we do need to bear in mind, come back to this later, that the price controls that we've achieved on insulin, first of all, one drug, why not all 300? But also, it's only if you have insurance that covers it. So what's been controlled is the copay cost, essentially, not the total cost and not the cost you pay if you don't have insurance coverage. So again, they didn't really attack the underlying problem, even if they did make it better for persons living with type 1 diabetes who have health insurance. Needless to say, the pharmaceutical industry makes great profits. They actually make greater profits than to the extent that they're still separable, the health insurance industry, equipment and supplies, and certainly us doctors and other healthcare providers are actually at the bottom end within the overall healthcare industry profits, as shown in this table. So the big pharma's lobbying, where they will always say, well, you can't cut the prices because we need that money for research. Well, let's look at what their actual spending practices are. First of all, by their own reports to the SEC and Wall Street and so forth, research and development is only 13% of their actual cost structure. And as you might imagine, that catch-all phrase of research and development includes a lot of things that scientists would not necessarily consider to be real research. That development is gobbling up an awful lot of money. It's marketing, it's manufacturing, it's profit, it's taxes, etc. We should also note that they are spending less on research than they are on stock buybacks and dividends. So if you look at their R&D expenditures on the bottom right, 521,817, compared to total buybacks and dividends, in other words, just playing finance games to make their stockholders, which include their own board of directors, wealthier, 577 is greater than 521. So again, this excess spending on buybacks and dividends is more than twice the amount that the Congressional Budget Office says could have been saved had we passed H.R. 3 over the same period. So, should it go to their profits or should it be savings to the taxpayers? You decide. Pharma revenues from U.S. sales exceeded the revenue from the entire rest of the world combined. So think of that for a moment. If you look at the top 20 top-selling drugs, the United States sales 101 billion. The entire rest of the world, that includes all of Europe, all of Asia, including the rich countries in Asia, Japan, Taiwan, South Korea, Australia, New Zealand, etc. So the context, the EU and UK alone has a larger population than the United States. And this is the entire, the EU and the UK and the entire rest of the world above and beyond that. So again, selling the same 20 drugs, they're making far more revenues in the United States than the rest of the world. So what's going on? Well, again, pharma, it turns out, has a higher return on revenue than the Fortune 500 average. Unlike the health insurance companies, which single payer pretty much just wants to put out of business. we love our drugs. I mean, I like to have my statin. I like to have my ARB. I like to have my blood pressure and my serum lipids controlled pharmaceutically. I don't want to threaten that. I do not want to put them out of business. I just want to pay the same price that France and Germany and Japan and Taiwan and Australia, New Zealand and Canada and Sweden and Denmark, et cetera, et cetera, et cetera. I want to pay the same price that they do for the same drugs from the same company. And in fact, what the US is subsidizing is not the ability of the drug companies to make a profit. What we're subsidizing is their excess profits, well and above, more than twice the Fortune 500 average. And that's what's being shown here, year in and year out. Pharma as a sector is doing 2 to 3 times the return on revenue as the Fortune 500 median. I just want them to have a fair return on revenue, similar to the rest of the Fortune 500 median, and not have to pay excess prices for my drugs. When it comes to real research, of course, the public is funding real innovation and research. Pharma says that all companies combined spent $83 billion in research and development. In fact, the Congressional Budget Office says that over half of that was just conducting mandated clinical trials to make sure that the drugs are safe and effective.
It looks like you're frozen, Steve, or maybe everybody else. No, just you, Steve.
Can hear you, Mike.
Maybe, Steve, maybe if you hear us, maybe try knocking down your video for now. That might strengthen your connection. Did we lose him?
Yeah, he's coming back on.
Yeah. You're muted
He's
now,
looking-
Steve, you're muted.
Yeah, he's
I'm
unmuting.
sorry, did I drop out somehow?
You froze up on our end.
I'm so sorry.
No, that's all right.
Are we back? Where are we back to?
You were talking probably for one more minute when you were frozen. So let's see, just back up just one frame.
How's that?
There you go.
Out here?
Yeah, yep.
So I was just saying here, the pharma revenue from US sales is greater than the entire rest of the world combined. So 101 billion for the 328 million people in the United States. The entire rest of the world, which includes the EU and UK, which is by itself larger than the population in the US, 57 billion. That's the EU, the UK, plus the entire rest of Central and Eastern Europe, Asia, Africa, Central and South America, Canada, and Mexico. So top selling drugs, they're making far more revenues in the United States, the much larger population of the entire rest of the world. So what's going on? Well, they have a higher return on revenue than the Fortune 500 average. And as I was saying before, I like my drugs. I like my statin. I like my ARB. I like to have my cholesterol and blood pressure controlled. So I don't want to put the drug companies out of business. Unlike the health insurance companies, which single payer essentially wants to put out of business, we don't want to put the drug companies out of business. We just want them to have the same fair profit, as it were, that the rest of the Fortune 500 make. But the return on revenue for the pharma sector is 2 to 3 times that of the Fortune 500 median. And I'm suggesting that the US prices, excess prices, as we've seen compared to the rest of the rich capitalist democracies around the world, the US is subsidizing with those higher prices the excess profits by pharma compared to the normal profits they make elsewhere by selling the drugs at a more fair price. And again, the US is the only country that doesn't negotiate prices from a position of monopsony. In other words, as a single buyer with the power to negotiate prices. And that's what the pharma industry has been blocking with their lobbying efforts in Congress, even in the limited negotiation of Medicare as is, being able to negotiate prices for all drugs rather than one here, or as of yesterday's announcement, 10 other drugs there. Well, what about the other 300 top selling drugs like every other country? And in fact, as other entities within the US, such as the Department of Defense, TRICARE, the VA, negotiate prices. Going back to the question, false excuse around research, this was pointing out that pharma claims that they're spending $83 billion on research and development. Congressional Budget Office points out that over half of that isn't really for new drugs. It's either for mandated clinical trials, which I guess is development, but it's certainly not the invention of the drugs. And it's certainly something they have to do for all the other countries as well. But an awful lot of it is really for the same drug, what they call a line extension of the same drug, coming up with maybe a new dosage or delivery system or a new combination of existing drugs, which allows them to extend the patent. So that's one down. Another down on their claims is that they claim about 2.6 billion per drug is how much they spend. Independent peer review analysis suggests it's about less than half that. And bottom line is, let's face it, the NIH, our taxpayer dollar, is the major source for all basic science biomedical research. And even pharma has acknowledged that at least one out of every $3 spent on drug research is coming from the American taxpayer. And that's not even including the amount that the British taxpayer or the German taxpayer is paying as well for their similar situations. NIH contributed to every one of the 210 new drugs approved by the FDA. And this doesn't even include the fact that there are tax advantage dollars flowing through nonprofit foundations, academic medical centers, et cetera, all of which are in effect a subsidy from the US taxpayer. And again, none of this is including the research that's paid for by other countries' governments. And I want to point out it was not always this bad. Let's remember, patent rights, quote unquote, are not actually rights. There is no such thing as a patent right. It's intellectual property law created and defined by government. Okay, there are no true libertarians out there. So-called libertarians usually want to enforce the police. They usually want to enforce the police power of the state to enforce patents and copyrights, right? That's what police and judges and jails are for. So there are no such thing as patent rights. There's patent law created and defined by government. And over the last 60 years, patent law has been systematically changed to favor pharma over people. And most infamously was the Bayh-Dole Act, which shifted intellectual property law to pharma even more. Before the Bayh-Dole Act of 1980, patents from publicly funded research were actually shared by the public. If the NIH funded your research, some part of that patent went to the federal government on behalf of the American people who had paid for it. After Bayh-Dole, only universities and the principal investigator could share, and the corporations that they then would contract with could share in it. They also put in some additional restrictions, making it harder to regulate patents and pricing. And they literally made it illegal for the public to share in the patent profits of publicly funded research. There's a bunch of, SOPs, if you will, that were supposed to make this more fair to the public. They're supposed to cite public funding in their patent application. Surprise, surprise, they don't always follow the law. They're supposed to make the drugs available on reasonable terms, which should mean reasonable prices, but apparently doesn't. It allows for the government to use what's called margin rights and grant a license to other manufacturers if those reasonable terms are not met. They have never been used. The margin rights have never been used, et cetera, et cetera, et cetera. If you want a really wonderful history of this, the Intercept link at the bottom is great. I remember it at the time. I was in college, and I remember articles of the Nation on this at the time. They just continued to lobby behind the scenes during the first 2 years of the Biden administration, when we had an ostensibly Democratic majority in both houses. They were trying to change the regulation behind the scenes with friendly bureaucrats in the federal agency who were mostly ex-lobbyists, and they were proposing bypassing Congress with margin rights, being able to exercise margin rights with secret lobbying around regulations. They abused their patents. Humira is a classic case example. Humira is the #1 drug in 2017, $18 billion in sale. And for the same molecule, they have put in 247 different patents over multiple different years. And the aim is to keep delaying competition and generics for Humira for as long as they can. So think of that, one molecule, 247 patents. Needless to say, pharma is the #1 lobbyist. You can see them here at the top by spending to federal lobbying. Insurance is #3, hospitals and nursing homes, health service, HMOs, and everyone's former favorite are the AMA and other health professionals, much lower down on the list, much less powerful. Again, lobbying. So again, how much pharma is spending on lobbying, and the number of lobbyists, including over 58% of them are former government employees. So again, you have that revolving door of government to lobby to government to lobby. And obviously, you know, this was a big deal, not just for the Republicans, but unfortunately for the Democrats as well, with folks going from pharma and insurance, then writing the ACA, going back to pharma insurance, then coming back with Biden and pushing for things like ACO REACH. And frankly, they just routinely break the law. So the rules around promoting drugs, actively promoting drugs for things that they were not actually tested for or approved for, and a variety of other illegal behavior where they actually got fined, where they actually got caught, actually got a judge or jury to agree. And it's just cost of doing business, because no individual human being that's actually making the decisions to do these among their executives ever goes to jail for this bad behavior. They just find the company, gets written off as a cost of doing business. So I'm sorry to say, after everything I've already said, but hey, it even gets worse. What are pharmacy benefit managers, and how have they made things worse? Well, they were invented a few years ago and sold to us as the idea of, let's put a middleman company, not government, let's put a middleman corporation in the middle between the drug companies, the insurance companies, and the patients and the pharmacies, and they'll negotiate the price down. So they'll cut a deal to negotiate a lower price for a limited number of drugs. And then, excuse me, we, the consumer, will pay a little bit less. Our insurance company will pay a little bit less. The drug company makes a little bit less, and the pharmacy benefit managing company makes a little bit out of that too. So instead of saying, well, let's do this universally at the national level with the government being the negotiator, what they said is, well, let's have a bunch of different companies, for-profit companies, act as yet another for-profit middleman, and somehow that's going to reduce costs. So as I'm explaining it, I hope you can all see just how ridiculous even the initial concept is. Additional for-profit middlemen don't save money, and they don't make things efficient. And this is kind of what it looks like. And I would suggest this is not what you would call saving the taxpayer money or efficiency, but it does tend to limit the number of drugs or diversity of drugs that the patient and doctor have access to. But what's happened since they were invented? Well, what's happened is vertical integration and monopoly power. So remember, the whole point of the PBM is it's supposed to be this independent third company negotiating the price between the health insurance plan and the pharmacy, right? That's presumably how it would work, to negotiate lower prices, keep some as their own profit, and pass the rest on to the savings and consumer. What happens if they're all the same company? So what happens if the insurance plan, Aetna, is the retail and wholesale pharmacy CVS and is the PBM Caremark? Similarly, Cigna is Express Scripts. Similarly, United Health is Optum. So what you wind up with is the big three are controlling 30%, 80% of the market share, and it's the health insurance company and the wholesale pharmacy and the retail pharmacy and the pharmacy benefit manager are all the same company. And so there are no savings to the consumer. There are no savings to the taxpayer or the patients. It's all accounting games where payments and charges and overhead just get shifted between different divisions within what's actually the same parent company. And so I would suggest that this is at a bigger picture level, we can just look at this as another way that additional layers of for-profit middlemen inherently never reduce costs or efficiency. And it's the same thing with Medicare Disadvantage, and it's the same thing with Medicaid managed care. Plus the problem of once you're done with your vertical integration, they have the monopoly power and we don't have the monopsony power. So PBMs are now sucking up 41% of Medicare drug dollars, and intermediaries as a whole are taking up 70% of it. And pharma, our earlier bet noir, the drug manufacturer, is actually only making 30%. So again, we've developed a system that just sucks the money out of the system for profit, takes it away from the patients, takes it away from the taxpayers. So what about on the outcome side? So again, it's the United States that's rationing care. One of the ways we ration care is we have a higher rate of people that are skipping their prescription drug doses because of costs. Here's the percentage of persons reporting it from other countries, and here it is in the United States. I should mention, we often point to Canada as being this great country when it comes to the healthcare system. I would actually suggest, sadly, and again, my wife's Canadian, I have lots of Canadian in-laws across many different provinces, that while the United States is the absolute worst of the rich and capitalist democracies around the world, Canada is actually about probably the second worst in a variety of ways. And one of them is their public system that we're often looking to does not include outpatient drugs in their public system. You have to buy supplemental insurance to pay for the public drugs, or guess what? You get it as an employee benefit from your employer, who might pay for that supplemental outpatient drug coverage. Sound familiar? So what's the cost related? So this is what we refer to as cost related medication non-adherence. This is, again, the patient's not taking the drug as prescribed, but phrasing it in a non-blame way, acknowledging that the reason that they're non-adherent is cost related. And again, what we see here, another study showing higher non-adherence in the United States due to costs than the other countries. And again, pre-Medicare within the United States and the pre-Medicare, if you will, post-Medicaid population, the 1964 working age adults, what we see here is those who do have some form of insurance for the entire year have a lower rate of not filling the prescriptions. And obviously folks with insurance have a higher rate to the point that it's a third of patients not filling the prescription. And then even if they fill it, they may not take it as prescribed. They may take, half the dose to stretch out the medication lasting longer before they have to refill it.
Steve, real quick.
Yes.
Yeah, just to be aware, we're right at the top of the hour.
Right, my apologies.
No,
Yeah,
no,
I
no.
need to run. Those that want to stick can stay on.
So I dropped your email in the chat, and
Yeah.
I will save the chat and send it around so that people can continue corresponding and talk about questions. Folks
Yeah.
want to know if you can make your slides available.
Yes, the slides and a video recording will be available shortly after.
Okay, so folks need to just write directly to Steve to make that request. And then for
And I'll
folks who
send
have
it
to
to
cut,
the,
folks who have
I
to
can
cut
send
out.
it out to OPS.
Yeah. Thanks for folks who have to cut out. Thank you so much again for all your support and for being here. And for folks who can stick around, just have at it. Keep going, Steve.
Thank you. So in terms, we talk about the folks being quote unquote non-compliant with taking their drugs because of the perceived costs. But what about hardcore outcomes, health outcomes from not taking it? Well, unfortunately, we have a bunch of natural experiments that have happened thanks to changes in health insurance, including with Medicare Advantage and others, where we see people going from a low copay to a high copay situation. And copays, remember the term skin in the game from the ACA debates, that point of service cost, in this case, copays for drugs, kills. Let me be blunt, it kills people. That's why we as single payer advocates are universally opposed to having to have these copays to get the drugs that the physicians have prescribed. What we see here is a study published by National Bureau of Economic Research that showed with a $10 chain increase in the copay in a prescription amongst first-year Medicare enrollees, what we saw was a drop in their taking a variety of necessary medications. These are basically things for heart disease and asthma and COPD and diabetes. And what we saw was an increase, a 33% increase in their mortality. So hardcore outcome, dead. Mortality rates up 33% due to, with a change of $10.40 increase in copay per prescription. Same study has been shown in a variety of other settings. So that prior slide is number 1 here. 2, 3, 4, and 5 were other examples. As a pediatrician, I was relatively horrified by the pediatric cancer survivors. Showed that adherence with the medications that they were being prescribed coming out of their cancer treatment, but the medications they still needed to be on, there was a variation in insurance coverage, and lo and behold, lower adherence with worse coverage. There's a dose effect. The odds of filling a prescription, this is one of the things we talk about. If you have a dose effect, it's likely to be causal. An association is more likely to be causal if you can show that there's a dose effect. Well, here the dose effect is the higher the copay, the odds of filling a prescription go down. Lo and behold. This is a chart that shows the insurer's prior authorization to refill a prescription from Cigna, jumping through all of the hoops between the doctor and the patient. And they list 26 different steps. So yeah, we don't have a very simple, cost-effective system. We just have one that deliberately makes it difficult for the patients and the doctors, but makes it increasing financial extraction by Wall Street. As in all else in the United States, there is a racial inequity component to this. Here are some reports specifically for how pharma's price gouging is killing Black and brown folks above and beyond the fact that it's also killing white folks. Alas, doctors are part of the problem. Most doctors take money from drug and device companies. Certain professions are particularly notorious on this: cardiology and psychiatry, heart disease, and depression, anxiety. And so-called not-for-profit leaders are collecting big paydays from pharma. What this is showing is specific individuals who are deans or CEOs at various not-for-profit health entities, Yale, Duke, Mayo Clinic, etc., Memorial Sloan Kettering. And what it shows in the second from the right column is their board pay, the amount that they're being paid to be the dean or director or CEO, and then how much they are getting in shares to also sit on the board of various companies. So they're getting millions and millions of dollars, many multiples of their pay, which for the entities, which gives them the status. But most of their pay is actually coming from shilling for or sitting on boards and making happy talk for these other drug companies. This is politically relevant because these folks will be the experts that will then go and say, well, as the head of the Mayo Clinic, as the head of Memorial Sloan Kettering, I don't think we should do yada, yada, yada to control drug prices. But of course, they're pocketing money far in excess of what their salaries that give them that standing are from the drug companies. It's just very corrupt. And again, a dose effect that as the amount of drug company payments going to physicians increases, the likelihood that those physicians will prescribe the brand name as opposed to the generic from the brand that's giving them the money goes up. So this claim that, oh, we doctors, we take the money, but we're not really affected by it, is obviously bullshit. And obviously the drug companies know it's bullshit, even if the doctors are kidding themselves. Impact on the hospitals. So actually one of the contributors to this slide set is a pharmacist employed by academic medical centers. And there's a hidden cost to the patients and the insurance companies by the raising costs to the hospitals for the drugs that the hospitals have to purchase that they're giving to patients on an inpatient basis. And just in the 3-year period from 2013 to 2015, they had an over 1/3, 38% increase in hospital drug spending. It's causing a strain on their budgets. And it's, again, far outpacing both the general inflation rate and it's outpacing the hospital, what the hospitals get in reimbursement from the insurance companies. And again, we think monopoly power is a huge piece of this. A drug called Daraprim had a 50 times price increase when the company that made and invented and actually did the research to develop Daraprim was bought out by Turing. Again, company that developed IV acetaminophen, bought out by another company, and immediately they turn around and do a 2.5 times price jack. And similarly for another drug called Isoprol. The point being, these are companies where it was just Wall Street games. One company took over another company. The first company is one that actually developed the drug, and just because they got bought out by somebody else, they then jacked the price up. It has nothing to do with the research and development, purely Wall Street gaming. And similarly, gaming patents abuse is the other huge one. So various ways where they extend the patent before, so it can't go to generic, or various ways where they, even if it's officially gone to generic, keep the prices high. And again, this is hugely frustrating. Every practicing physician and other prescribers, like nurse practitioners, have horror stories about their patients not being able to fill their prescriptions as given and having health consequences or death. Frontline pharmacists. I mean, if you're a pharmacist working at Walgreens or CVS, imagine you're the front line when the person comes up and says, what do you mean I have to pay $30 to get my drugs? They're the ones getting yelled at. They're the ones, in some cases, even being assaulted. So again, they're the front line facing the public, bearing the brunt of the anger. Furthermore, these monopoly chains like CVS and so forth, Walgreens, they've been putting all of the mom and pop pharmacies out of business And pharmacists as employees are suffering the same kind of burnout, moral hazard that the doctors and every other healthcare worker is facing. And sad to say. So what are we going to do about it? Well, the short answer is we should bring in single payer, which puts us on the level playing field with all those other rich capitalist democracies around the world, all of which engage in negotiating prices at a macro level. Only the United States among them doesn't have that monopsony. Buyer has monopoly power. There shouldn't be any copays or deductibles. We need to remove all point of service costs. And we need to have complete transparency on the medication formulary so the doctors know what to prescribe and can argue if something's not on the formulary. There's a variety of actions that we can do to roll back drug prices, that all public programs should be able to negotiate all drug prices, not just a short list of, well, insulin 1 year and a couple of others another year. We have examples in the U.S. already with the VA, DOD, TRICARE, Medicaid, a program called 340B. It's the same as presumably the prescription benefit managers were supposed to do. And it's noticed that, as pointed out, it's what all the other countries do. When we're doing this, we need to distinguish, are we negotiating the price of the drug or a price cap, cost cap, copay caps, or out-of-pocket caps? These are different things, and the copay cap only applies if they have insurance that covers drugs. Other things we could do is allow importation at their prices from other peer countries like Canada. By the way, Canada is not necessarily keen on us diverting their drug supply to the United States. If you think about it that way, Canadians, it's actually an issue in their op-ed pages. We could enforce the existing law under Bayh-Dole, like the march-in rights and reasonable pricing, which we've never done. And a variety of other things here, reform Bayh-Dole to allow taxpayers to once again share the patent rights for the research that they've paid for, we've paid for, stopping the abuse of patents with lookalikes, combos, extended release, and generic capture, reduce the monopoly pricing power, delinking the patents with prescription sales, mandatory earlier independent generic manufacturing, more public R&D, and more public manufacturing, which has been suggested. Italy, for example, has some of that. And again, we ought to be paying for true effectiveness and comparative effectiveness research. The current system of FDA-mandated trials is run by the self-interested drug companies, and so what you get is, look-alike knockoff drug compared to placebo, and you never get look-alike knockoff drug A compared to look-alike knockoff drug B compared to each other to see if there really is a difference or not. And that's really a bad problem. And I am finally done. So thank you very much, those who bear with this. And let me open up chat, although I guess if you put stuff into chat earlier, I might have missed it. So yes, I will send a video of the whole thing. I will send the slides. And for those that stuck around, I am happy to take questions.
Wow, thanks, Steve. We got a hand already. Michael Bacon. Unmute.
Yeah, do you think individual states would have enough power to negotiate drug prices with Big Pharma?
Yes, individual states have already done so, mostly in the insulin arena. But again, there's no reason they couldn't do it for others. So there are bills in various states to do just that.
Another question, Michael?
Just one more. This is kind of a detail, but the government now, they negotiate the wholesale prices, is that right? And then
No,
the
the
individual
government,
pharmacy.
not for Medicare. So we negotiate the prices. TRICARE and DOD negotiate prices for military. The VA negotiates prices for the VA. There's some negotiation with Medicaid and a program called 340B. There is now written in the IRA, the version of Build Back Better that we got, the version of HR 3 that we actually got, watered down, that has limited the copay out-of-pocket costs for insulin. But it's haphazard.
But what are the implications for the retail pharmacies? That they would have to add some markup to cover their overhead and maybe a little bit of profit. Would those
Yeah, I
be
mean, basically, I mean, bearing in mind, that, CVS, Aetna, same company, has some leverage in negotiating, let's say, with Pfizer. But mom and pop, pharmacy doesn't have as much leverage, and not surprisingly, I mean, I presume there's a wholesaler in between most mom and pops and Pfizer. But yeah, there's a problem there. Bill Simple, you got your hand up. Bill, you're
I'm
muted.
trying to raise my hand. I can't find it.
Barbara, you're next. Bill's
Okay.
on mute, then Barbara,
I just wanted to answer.
and then Sharon.
Yeah. I just wanted to answer. This is Barbara Pearson. I just wanted to answer Michael. I think that Vermont decided that they probably couldn't have enough, be big enough, but I think almost every other state could do it. Maybe not Wyoming or something. but
I think
almost every
my
other state has
recollection was,
enough.
I know there's been a
Surprising.
bill.
I mean, the
in
VA is
this-
tiny compared to states, and they're half. They get paid half. They pay half.
I know that in New York, we had legislation
That's all.
that didn't pass, but it was fought for, and it was thought to at least be legal, that was going to limit the insulin prices, or the insulin co-pays and out-of-pockets, prior to the federal bill. And I thought there was stuff like this in California as well. So some states are doing something on the same very limited basis, not across the entire formulary, but a drug here or a program there. Sharon, I'm sorry, Bill, and then Sharon.
Yeah, wondering, could a single payer in a state, at a state level, just say, we'll pay whatever the VA pays and not have to do all the negotiating, but just, so just say
Right.
we'll pay whatever the VA pays.
Yeah, I think that makes perfect sense, that if you have a state-based single payer like the New York Health Act or whatever it is in your state, that they would then be able to exercise statewide monopoly power. If you want to sell in New York State, this is the price we'll pay. And hopefully there's enough competition out there that somebody will do it. And certainly, having the VA or DOD TRICARE pricing as a model would be great. I mean, they may not accept the Canada model or the French model, but if it's already in the US, you would hope they would be willing. Sharon.
Yes, you had mentioned that the 340B statute was a way of saving money on prescriptions, but I'm not sure, maybe you're aware, but maybe some people in the audiences are not aware of how that's actually being used.
And abused.
Yes, because the hospitals are sometimes, they get the drug for less, and then they charge the patient more, and sometimes even more than a normal patient would pay.
Yeah.
They send that to the
340B is very controversial because of abuse by large medical centers. Absolutely. The flip side of it is some of our friends in the federally qualified community health centers, the FQHCs, are actually dependent on their own financial schemes, their own financial means to keep the FQHC open, in part because of the profit they make off their 340B program. It's 340B is a huge mess. It was actually the agency that does it. HRSA is the agency I worked for the last 24 years of my career. So unfortunately, I'm familiar with it. Yeah, it's a little teeny carve out in the great scheme of things. Somebody says, was having the question about what about the single D? To answer your question. So the VA and DoD systems, TRICARE, under single payer remain in place. So there's some carve outs under single payer bills. Generally, they don't include the VA, they don't include the DoD, and they don't include the Indian Health Service, the tribal, are generally carve outs. What is the difference between VA and TRICARE? So TRICARE is for active duty, and VA is for retired. So if you go, first of all, if you're active duty and you have a big base near you, you might go to the base hospital, and the base hospital or clinic has military employees as your providers of care, and you're getting it from the military on base pharmacy. But if you're uniformed services and not near a base, then you have this other coverage that's called TRICARE. I'm one of the few people in single payer is familiar with this because I was U.S. Public Health Service. So TRICARE is the healthcare I had for 30 years. Other questions? I'm sorry. Sharon and then Mike.
Yeah, I think you could get TRICARE for life also, right? I mean, this is probably what you would
Yeah,
be.
it sucks. Oh, I'm sorry. TRICARE for life is great. So TRICARE for life, I'm sorry, there's something else. So TRICARE for life is if you're eligible for TRICARE, which I am, it covers you and your wife, in my case, your spouse. And it's essentially a Medigap. It's essentially a really good Medigap program as a benefit. So what I have is a really, really good Medigap, no copays, no, well, I have to pay the Part B premium, but no, no limited network, no, anyone who takes Medicare, I just go to any Medicare provider, and then I have my Medigap coverage above and beyond. So that's TRICARE for life. It's just your basic Medigap, and avoids having to do, a Medicare disadvantage. There's another one that's like TRICARE for young adults, which is for your dependents over the age of 21. It sucks. The premiums are through the roof. Any other available coverage is better than that one.
So I still have a point.
Yes.
One is potential allies, some from friendly sources, others from strange forces like AARP. Can we join forces like for Oregon has Oregon Pharmacy Association?
Yes.
Can we gather allies to lobby better than we are? Are you doing that in New York?
Yes, we are in New York. So there are different, to talk about the pharmacy groups, there are different pharmacy groups, or pharmacist groups, I should say. So there's a group that represents the hospitals and institutions. At least in New York, they have their own association, and I think nationally they do too. Then there's the one that represents the mom and pop, the independent pharmacists, or independent pharmacies, the independent retail pharmacies. They have their own organization. Those two ought to be on our side and are worth lobbying. They are both, especially the mom and pop one, the independent pharmacist group, they are, CVS and Walgreens has their own lobbying arm, of course. And since they're also the insurance companies and they're also the PBMs, they're probably not going to be on our side. So pharmacists, lobbying groups or associations, they're different ones, and you got to keep track of who they're representing and what their interests are.
Yeah, what was the first group that before you mentioned mom and pop independents?
The ones that represent institution, that are employed, represent institution, like the hospital pharmacists, the nursing, the pharmacists for the hospitals, or along networks and things like that. So they were, at least in New York, they were good guys with us. Until,
how do you
well,
cooperate?
until their hospital CEO shut them down. Because the hospital association is not in favor, even though they should be.
And then how to cooperate with a group like AARP.
Your guess is as good as mine. I mean, it is interesting that there occasionally, when there's bills in Congress, you will see you'll see pharma, which is actually the name PHRMA of the lobbying group for the drug companies. You'll see their lobbying grenades of accusation at the insurance companies at AHIP. So, and AHIP will lob grenades at pharma, right? So the insurance companies, they're happy to have the drug costs less, right? I mean,
Yeah.
Aetna and CVS would love to pay Pfizer less, right? And Pfizer would love to get more money from Aetna and CVS. So they're both our enemy, but they're sometimes not in sync with each other.
Right. Well,
And we've
Steve,
seen this. I mean, I've seen the ads that they run during when there's a particular bill, and you'll literally have AHIP bashing pharma and pharma bashing AHIP.
yeah. Steve, thank you
of
so,
course, there's
so
the
much.
old saying, when elephants fight, the mice get crushed.
Yeah. Thanks, Steve. I think we have answered so many questions, and appreciate your time, willingness to do this, and also being on the board of One Payer States. And I love your T-shirt, the QR code. I don't know if you want to mention that again.
Yeah, so I've made up 10 of these T-shirts for Chicago. So if anybody's in Chicago, find me. Hopefully I'll find Chuck early. I'm dropping my cell phone as well. I've got 10 shirts. One of them is mine. The front is the Heal Medicare PNHP carve out against Medicare Disadvantage, and the back is Sabuca. So I'm a walking sandwich board with the T-shirt.
Great.
This is one we had in New York. So for the New York Health Act.
That's good.
Which I love.
Yeah.
So, yeah, I'll duck out of the way. So
there, and I've tested your QR and it works.
Yes, I tested them before I gave the guy approval.
So I'm going to ask. I better let Dee ask her question. You got to unmute, Dee. Yeah.
You're doing in terms of getting a single payer bill in the state?
Well, I'm sorry. We have one in New York that is, I think, as far along as anything in the country.
Okay.
New York Health Act. It passed in prior years. It passed the Assembly 4 or 5 different years in a row. Now that was, of course, when they knew the Senate wouldn't pass it. The moment we had a Democratic supermajority in our state Senate, the Assembly wouldn't bring it to the floor. We've seen that before. We nominally have a majority of co-sponsors in both the Assembly and the Senate. So a majority in both houses of the state legislature have signed on to the New York Health Act. Overwhelming majority of Democrats. I mean, almost every Democrat has signed on to it. Leadership is keeping it from actually coming to a vote. And of course, what they all point to is, oh, well, this should be done nationally. And of course, national says, let's do it in the states.
Yeah.
But the other issue is officially the reason that the progressives won't bring it to a vote in New York is we have a bit of a struggle with the public service unions. So the unions representing public service employees, New York City teachers, for example, that sort of thing, because they have such good benefits, they claim, and the leadership claims that that's one of their deliverables to their members. Therefore, they're opposed to the New York Health Act, even though it has written into it specifically to cover this issue that, you know, everything that's currently covered in any public sector union is automatic. I mean, New York Health Act basically is language that says if it's in Medicare, Medicaid, S-CHIP, or any public service union, it's covered in the New York Health Act. And it also covers the, well, what if you work in New Jersey but live in New York? You're covered. What if you live, what if it's flipped?
Yeah,
So if you're full-time, if you live in New Jersey and work full-time in New York, and full-time is what, 30 hours, whatever the definition is of full-time, 30 hours, then you're covered.
yeah,
So all of those sort of, you know, and then there's the, well, what if I'm a retiree and I move to Florida, you know?
yeah, that's a good
Right.
question.
Okay, you froze again, Steve. I don't know if you can drop your video, or maybe this is the end of the meeting in any case. I think we've reached everybody's limit. As much as I'd like to hear Steve more, and thank everybody for attending. And we'll
Thanks, Mike.
send out the recording. Oh yeah, yeah. Bill, do you have a question?
No, I was just waving goodbye.
Okay. All right. We'll
Thank you.
send out the recording and actually an otter transcription and outline of his talk. I'm pretty sure we can get that to you soon. And his slides.
Great,
Okay. Thanks.
thank you.
Donate to One Pair States, please.